Hi, guys. Thanks for keeping on listening. We are away on parental leave right now.
Yes, but we still wanted to make sure that you guys had content to listen to while we were away. So here is one of our oldies but goodies.
Check out the website for some updated notes on this particular episode since our recording. Hope you enjoy, and we'll see you when we're back.
All right, guys, welcome back. This is Faye.
This is Nick.
And this is
Creogs
Over Coffee. Today we have with us Dr. Aparna Sridhar. She is an associate clinical professor in the Department of Obstetrics and Gynecology at UCLA, and she is also fellowship trained in family planning. And today, Dr. Sridhar is going to be talking to us about combined hormonal contraceptives. So welcome.
Thank you.
All right. Dr. Sridhar gave us some learning objectives for today. And just to review, number one, we'll talk about understanding the endocrinology of combined hormonal contraceptive. Secondly, we'll learn how to select the appropriate combined hormonal contraceptive therapy based on the medical history, which is what I'm most excited about today. And then finally, we'll talk about key aspects of prescription and follow-up from here. I guess let's jump right into it. Let's talk first about endocrinology of this particular contraceptive. There are two components to these pills, right?
Right. So as the name suggests, combined hormonal contraceptives include those which contain both estrogen and progestin component. The estrogen is the added, like the main benefit of the estrogen is for cycle control. There is a small contribution to the suppression of ovulation. If you think about all the hormonal contraceptive methods available in the market, only those containing estrogen have like high chance of giving you like the perfect menstrual cycle-like feeling with cyclical bleeding. So that's the benefit estrogen brings into this mix. Natural estradiol that's actually produced by the ovaries has very low bioavailability, so it's not great for cycle control. So almost all of the combined hormonal contraceptives available in the market contain the synthetic form, which is like the ethinyl estradiol as the estrogen component. The dose of this varies from 10 microgram to 50 micrograms. Very few formulations actually have 10 or 50 micrograms at this point in time, and majority have some kind of dose in between. For example, the contraceptive rings that are in the market, they release about 15 micrograms of ethinyl estradiol per day. The patch has two different patches. One has about 30, the other one has 35 micrograms. And the pills mostly range from 10 to 35, with few of them having 10 and 50 micrograms of ethinyl estradiol. So how would this make, difference? Like how would the dose make a difference? There can be dose-dependent effects in terms of like the side effects. For example, venous thromboembolism. There can be dose-dependent bleeding changes that can happen. For example, like low-dose ethinyl estradiol formulations may not form that thick of a lining. So you may actually have sometimes higher rates of amenorrhea, but it can also not sustain the endometrial lining that much and may cause some more bleeding in between the periods too. So I think that's where ethinyl estradiol component comes in. And is ethinyl estradiol the only estrogen formulation is there? Not really. We also have some newer formulations. They have estradiol esters such as estradiol valrate in some of the newer formulations. And jumping to progestins, progestin does give the main contraceptive benefit. I think I heard a great podcast from you guys from Dr. Ben Brown. So that does talk about a lot about progestins and mechanism of action and the different types of progestins. So I would probably refer the listeners to that podcast for details. But just as an overview, there are many different synthetic progestins in the market. Again, natural progesterone is poorly absorbed and rapidly metabolized, so we do use synthetic progestins. And these progestins have evolved over time. Although in the past we used to say generations, we are really trying not to use that term anymore because the first generation is really not like an old one compared to the fourth. They're all kind of, different in terms of the how they are actually, whether they are like their structure and their function. So the main difference between each progestin is how they differ in their androgenicity, potency, and some of the non-contraceptive benefits. For example, levonorgestrel, this is kind of it has longer half-life. So you remember like levonorgestrel is the one that's in IUDs and everything. So for someone with heavy menstrual bleeding, probably a oral contraceptive with levonorgestrel might be a better one. And the spironolactone analog drospirenone actually is probably better for acne because it has that, spironolactone component or, spironolactone-like action on it. So that's how the progestins differ. And that kind of sums up the endocrinology of these methods.
Dr. Sridhar, can you talk to us a little bit about the different types of combined hormonal contraceptives? I mean, I think, we like always talk about the pill and it seems like there's so many different types of pills, but what are like other, types of combined hormonal contraceptives?
Sure. You kind of said it, Faye. The combined hormonal contraceptive pills, there are many different formulations, right? So one of the most commonly used contraceptives in the United States, with I think more than 25% of the contraceptive users use this method. And more so because, such an easy contraceptive method to take. Just pop a pill in your mouth every day and that's it. That's like the combined oral contraceptive pills. And I think we can go into the details of the cyclic patterns within the oral contraceptive pills next. But other than the pills, we have contraceptive rings. As of March 2021, where we are recording this podcast, we have two main formulations of rings. One is ethinyl estradiol and etonorgestrel ring. Popularly, we're not promoting any brands, but that's kind of the newer ring, which is the brand which is very popular. It is inserted for 21 consecutive days and removed for 7 days each cycle. So meaning every cycle you use a new ring. And then now we have a new ring in the market, which is ethinyl estradiol and progesterone acetate ring, also known as Anovera. And that's inserted for 21 continuous days and removed for 7 days. But the same ring is used for 13 consecutive cycles. So it's kind of a long-acting one considering you only need one ring for the 13-cycle duration. So those are the two ring formulations available. And then we have contraceptive patch. And currently we have two contraceptive patch available. They kind of differ by ethinyl estradiol, either 35 micrograms with norelgestromin as one of the formulation, or we have 30 microgram of ethinyl estradiol and levonorgestrel as the second formulation. So these are kind of the overview of all the different combined hormonal contraceptives available in the market at this point in time.
I want to come back to one of the points that you raised about the oral contraceptive pills. And you mentioned that there are a lot of different formulations and a lot of different cycling things. I know that I feel like as a resident, I kind of picked my standard pill that was like one of the 21/7 regimens. But as I've like read and heard more, I know that there are these ones that can go for like 84 days in a row, or, some of these, I've never touched a triphasic pill, I think, but I've heard that word thrown around. Can you talk us through some of that and sort of what those look like?
Definitely. Historically, when birth control pills were developed, they were developed to mimic natural menstrual cycle. It was more for the acceptance at that point in time than anything. But now we know that the scheduled bleeding is not like biologically necessary, and suppression of menstruation is actually sometimes beneficial for us. So there are many different cyclic patterns that are available in the current existing pill formulations. And let's start by understanding the monophasic regimen. So the monophasic regimen contains same dose of estrogen and progestin, but the number of placebo pills vary. So like Nick, as you mentioned, the 21/7 regimen contains 21 active pills and 7 placebo pills. And most of the older forms of the birth control pill formulations were usually a 21/7 regimen. But you have to be careful with these because any hormone-free interval of more than 7 days actually increases the risk of breakthrough ovulation. So you have to take them every day at the same time and do not miss that extra more than that 7 days dose. Then came the 24/4 formulations are there. They shorten the hormone-free days. So one, they increase the efficacy. And because there are less hormone-free days, all the kind of menstruation-related symptoms are less frequent because there's only 4 days of that. So that's the 24/4 formulation. The other monophasic regimen is our extended cycle regimen. So they'll have monophasic pills with 30 micrograms of ethinyl estradiol and levonorgestrel used continuously for 3 months, followed by 1 week of either placebo pills or 10 micrograms of ethinyl estradiol pills. So these are marketed as the extended cycle regimen, but remember, most of the birth control pills actually can be used in the extended cycle regimen. This not only kind of increases the efficacy, but it also minimizes the menstruation-related symptoms because you're really having 3 menstrual cycles in 1 year. So that's kind of the pills in 3 different monophasic regimens, 21/7, 24/4, and then the extended cycle. If you really think about what about the patch and the ring, there is data about extended continuous vaginal ring usage, and it is considered to be safe, but not much data out there about the safety of the extended cycle patch use. So most commonly, ring is used in an extended cycle format. Now, what about the multiphasic regimen, right? They contain different doses of either estrogen or progestin, or sometimes both each week. For example, triphasic regimen will have probably 3 different dosing per week. And you can recognize these pills because there is usually a tri in their name, like orthotricycline, trinessa, things like that. So the multiphasic oral contraceptive regimen, I think initially they developed these in the intention of mimicking the natural cycle or decreasing the breakthrough bleeding. But I don't really know if there is enough data to prove whether multiphasic is really beneficial. So I usually kind of go for monophasic for the most part with, the lowest form of estrogen, and then kind of think about the non-contraceptive benefits.
That's really awesome because like Nick was saying, I don't feel like I was very comfortable prescribing any type of multiphasic regimen. And, I think that is a great explanation of all of the different types. Can you also talk to us a little bit about the safety of combined hormonal contraceptives? Because I think a lot of our patients are concerned about having something with estrogen in them. And sometimes, of course, they do have medical conditions where, they may not be eligible to get some type of contraceptive that has estrogen.
Definitely, Faye. So we are all aware of the CDC's medical eligibility criteria, which includes recommendation for using a particular contraceptive method for those patients who have certain characteristics or certain medical conditions. Right. So the USMEC is our guide to say which contraceptive can be used safely in a particular patient with particular set of either medical conditions or personal characteristics. So this USMEC actually combines pill, patch, and ring in one group as combined hormonal contraceptives. And that's why I think I think we are talking about all of them together because there is comparable safety, the pharmacokinetic principles and profiles for all these delivery forms are pretty much similar. So if you look at the USMEC, the most common contraindications, and these are in USMEC, you have category 1, 2, 3, and 4, with 1 completely safe, 2 benefits overweigh the risk, 3 the risks overweigh the benefits, and number 4 would be completely not okay, completely contraindication. And if you really take number 4, breastfeeding and less than 21 days postpartum, smokers over the age of 35 who smoke more than 15 cigarettes per day, more so for the increased risk of cardiovascular disease, especially myocardial infarction, multiple risk factors for cardiovascular disease, severe hypertension, acute or history of DVT-PE, known thrombogenic mutations, history of stroke, pulmonary hypertension, antiphospholipid antibody syndrome, migraines with aura, current or recent breast cancer, severe cirrhosis. These are all like absolute contraindications for combined hormonal contraceptives. One thing to remember, which is kind of different for pill, patch, and ring, is someone with bariatric surgery, especially with the malabsorptive procedures. The pills are considered, category 3, where you really use it if there is significant benefit, and even, you could potentially think about the risk. But patch and ring are considered like safe and category 1 because there is no oral absorption. So apart from that, that's like one condition wherein there is difference between pill, patch, and ring, but majority of the time the contraindications are very similar. So when we keep safety in mind, we need to get a thorough medical history to make sure there is no contraindication for estrogen usage.
No, that was really nice. And I kind of I've always wondered about that too, of why all of those were lumped together, but that's a very helpful explanation, actually. No discussion of contraception would be complete without talking about efficacy. So what about the efficacy of these varying methods with combined hormonal contraceptives? Are they, I assume that they're that good because they've been around for so long, but what are the pitfalls? What are the risks, etc.?
Right. When we talk about the efficacy, we think about it in two different terms, right? Either typical use versus perfect use. I always tell my patients, like, nothing is perfect in life. So we got to go by the typical use failure rates, which expresses the effectiveness, who use the method, including those who use it like inconsistently or incorrectly, because we do forget, we may insert it late. Things like that will happen. So considering that, I always quote a typical use failure rates for women, because perfect use is done perfectly and correctly. That's the failure rate that we talk about with the perfect use. For pill, patch, and ring, there is about 7% of women become pregnant in the first year of use. This is kind of the recent data from the Guttmacher Institute. And the perfect use failure rate is less than 1%, like 0.3%. But I would still quote the typical use failure rate. And sometimes I think, the more human input that we need to do, like taking a pill every day versus, having a patch every week, changing it every week, and using the ring like 21 days and 7 days. So there is that, thing that we need to do, which increases the risk of error. But there are a lot of technological advances now, reminders and text-based reminders, app-based reminders that women are using, which actually makes them take it exactly at the same time every day, which improves the efficacy significantly.
One question that I think, I was really interested in for this podcast is just, how do you start someone on a combined hormonal contraceptive, right? Like, how do you pick which one to start someone on? And then what if someone comes to you and they're like, I hate this pill because it's making me have breakthrough bleeding, or I hate this pill because it's making me gain weight or have facial hair or whatever. How do you troubleshoot those problems and figure out what to do?
Right. So the first and foremost thing you need to, make sure is safety. And once you ruled out all the contraindication, the next thing you may want to ask someone is, do they want to bleed monthly, or is there any benefit from, skipping the cycle? Obviously, if there is benefit from skipping menstrual cycle, you go towards an extended cycle regimen. But if they do want monthly menstrual cycle for preference, or for feeling like they're having a period, or any reason that women may choose to have that, then I would probably think about the lowest dose of the ethinyl estradiol or any estrogen component available, because remember, that's the one that is dose dependent risks associated with it. So probably the lowest dose is good to start with. And then depending on what type of non-contraceptive benefits they want, which, we can go into the details of that as well, then you pick like a progestin that's probably the best suited for someone with like a particular need for a non-contraceptive benefit. And then that would be the pill that you would choose. Or if they don't want to take it on a daily basis, you may kind of offer them a patch or a ring to go with that. So that will be the first step to start, right? So now how to start? There is a great resource, which I think you guys touched on it on the Progestin Only Method podcast as well. It's called Selective Practice Recommendation. Again, it's in the same mobile application as the contraception one from CDC. So it's a great guide for all practical aspects of prescription and also to kind of follow any problems associated with it. So the combined hormonal contraceptive methods, whether it's pill, patch, or ring, can be started at any time as long as we are reasonably certain that our patient is not pregnant. And that's the only criteria for starting. So you could start like at that day, you can make them start on a Sunday, depending on when they want to kind of start it, it's fine as long as we reasonably make sure they're not pregnant. And how do we do that? They shouldn't have had any sex after their last normal menses. They should be using correctly and consistently a reliable form of contraception, or they're less than or equal to 7 days after a spontaneous or induced abortion, or within 4 weeks postpartum, or more than 85% of the feeds, if they're breastfeeding, are actually coming from complete exclusive breastfeeding, not even pumping for that matter for the most part, and they have to be less than 6 months postpartum. So if they meet all these criteria and you're reliably certain that they're not pregnant, you could pretty much start them on anything. If you start them within 5 days of the menstrual bleeding, you really don't need any protection and on top of it. But if you don't, you need additional protection for about 7 days, right? So that's how you give it to them. I usually give them, if it is like pill, patch, or ring, like I give them more than one at a time, like at least 3 with like 4 refills or more than that if their insurance actually pays for it, because that's known to make them take it regularly so they don't have to go back and forth to the pharmacy. And once you send them home, you do have they have some problems associated with it. And the most common one, as Faye mentioned, is actually the breakthrough bleeding. This is kind of bleeding that happens while taking the birth control pills, and it resolves in about 3 to 6 months with consistent use. So the first and foremost thing is to make sure they're taking the pill or patch or ring consistently. Like we told them, no delayed insertions or missing a pill or taking it late. That might solve the problem for the most part. But if those things are not solving the problem, there's always room to rule out any other gynecological conditions. They may be having a polyp or cervicitis or something else going on. And if still bleeding, then you may either have to change formulation. For example, if they're on a progestin like norethindrone, which is a short-acting progestin, you may want to switch them to levonorgestrel or a higher potency progestin, and that may change it. Or if they're on a lower dose ethinyl estradiol, you may try to kind of increase the dose, although that's kind of controversial. Usually a change in the progestin is better, but if not, you can try changing the ethinyl estradiol level. But if everything fails, sometimes like if they're on like a continuous regimen and they've done it for 2 months and they're still bleeding, you could probably give a hormone-free interval of 3 to 4 days just to reset, and then have them start again. And these are some of the things that we can do to manage some of the breakthrough bleeding. The selective practice recommendation has beautiful charts for missed pills or late insertion or late usage of these pill, patch, and ring. So I strongly urge all the listeners to download that app and look into it if you do have patients coming with either missed pills or, didn't take the patch right or forgot, putting the ring on time and things like that.
Definitely a handy app for those middle of the night phone calls of like, what do I do now? um, I guess one of the things that I've always thought about hormonal contraceptive as for a gynecologist is like our version of a Swiss Army knife, right? Like it seems like we use it for cycle control and contraception, but there's a lot of other benefits to using it too that we can prescribe to basically get intended other effects. Are you able to talk to us about some of those?
Yeah, let's kind of talk about some of the main things, right? So the most common one is bleeding regulation. Abnormal uterine bleeding, like AUBO, related to ovulation, um, either because of adolescence, perimenopause, or PCOS, whatever could be the reason. I think that's one of the most common reasons. There might be desire for amenorrhea. I can give an example of those with developmental delay who are dependent on caregivers, and you really don't want them bleeding every single time. So sometimes there is like benefit with amenorrhea, or sometimes scheduled bleeding is personal preference. So whatever may be the reason, bleeding regulation is one of the most common non-contraceptive benefits. And we know that combined hormonal contraceptives do decrease the amount of flow, and also like significantly improve like the bleeding, heavy menstrual bleeding. So if you were to pick a progestin, I would probably pick a levonorgestrel or pick an extended cycle regimen, right? So you actually have less frequent menstrual cycles, and that may really help with that. So that is kind of, the bleeding regulation and abnormal uterine bleeding. The next one is usually management of dysmenorrhea. Significantly, combined hormonal contraceptives reduce dysmenorrhea, especially for adolescents. Like long-term NSAID use is also not that great. So I think if you're really looking for a long-term option for controlling dysmenorrhea, low-dose combined hormonal contraceptives or low-dose oral contraceptive pills too are really great. And again, if they're missing school with like severe adolescents, for example, or missing school or work or anything with severe dysmenorrhea, extended cycle regimen is also great because again, less number of periods, less number of days with pain, and significant improvement in quality of life. Along the same line of dysmenorrhea is like the endometriosis treatment. We clearly know that there is like significantly lower incidence of endometriosis and reduction in like the formation of endometrioma with the oral contraceptive pills have been studied extensively on it. And also, I think there are studies that say that if you take like a surgical resection of endometrioma and put them on the combined or hormonal contraceptive, that's also beneficial for them. Significantly reduces the menstrual pain. Usually we go for either like an extended cycle regimen because there is less number of cycles, but also the extended cycle regimens, they prevent like the pseudo-distalization of the endometriotic implant. So that also helps with the endometriosis patients. But we have to remember this is not curative, meaning once we stop it, things may come back, but definitely suppresses the symptoms of endometriosis. So that's another significant benefit that we think of. Mood-wise, like PMS and PMDD management is really kind of dependent on this too. And for that, I think FDA-approved treatment with the drospirenone containing combined oral contraceptives as a treatment option to reduce like PMS and PMDD symptoms. And that's been pretty much studied well. So that's actually another non-contraceptive use. And the other most common one is acne. It's kind of a delayed benefit. I always have to remind my patients that it may take up to 6 months, because remember that combined oral contraceptives or any combined hormonal contraceptives, they act by suppressing the ovulation, the ovarian production of like androgens, and also by inducing the hepatic production of the sex hormone binding globulin, which binds to the testosterone, and thus there's like that delayed effect. So it's not immediate, but definitely useful. I always the FDA actually approved only 3 different pills for acne protection. I think it's orthocycline, which has norgestimate, Estostep, which has norethindrone, and Yaz has drostatinone in it. So even though it's the brands that are approved, but most of the generic formulations, which by the way have pretty good bioequivalence compared to the brand products, also work similarly. So that's a great additional benefit. And last but not the least, I also wanted to put a word about these functional ovarian cysts, right? So these people who you see in the ER with hemorrhagic cysts and who come in back and forth with cyst management, those are other people, again, birth control pills or combined hormonal contraceptives they're not going to prevent or treat, but extended cycle regimens usually can reduce the formation of these as well. So, I mean, we can keep going, but these are some of the most common one. And again, recently, I think there was a lot of press about cancer protection. As we know, ovarian cancer, 50% reduction almost, endometrial cancer, about 30% reduction, and 15 to 20% reduction like colon cancer. So, I mean, we can keep listing the goodness of these combined hormonal contraceptives in terms of the non-contraceptive benefit, but these were some of the main things that I wanted to highlight.
And I guess just kind of like the last thing to just touch on, can you also talk a little bit about the risks or disadvantages of being on combined hormonal contraceptives?
Right. So the most common one is you have to do something on a periodic basis. So convenience is one great advantage, but at the same time, there is room for error. So that's one of the disadvantages. But if we really talk about the risks, again, the most serious, but again, rare, is the VTE or the venous thromboembolism risk, right? So it is usually due to estrogen component and is dose dependent. And that's why I think that's one thing that we do need to talk about when we talk about the risks of combined hormonal contraceptives, because they all contain this estrogen component. Progestins by itself, they have no impact, but I think when combined with estrogen, some can modulate the strength of the estrogen's production of these clotting factors. But really, it's the estrogen that makes it thrombogenic. Though I think the relative risk of thrombosis is definitely higher in the combined hormonal contraceptive users, but it's the absolute risk of thrombosis is still a rare event in like a healthy young user. So I always have to tell my patients that yes, if they Google about it, they will read about this and it is a risk, and I do talk to them about it. But the risk is really rare in young, healthy individual, but the risk does increase with age, increased BMI, those who are smokers, and those who are on the higher estrogen dosage. So I think all the more reason not to start people on higher doses unless absolutely essential, and also to keep in mind all the additional risk factor when we are starting someone on combined hormonal contraceptives, because that's something that we need to keep in mind. Similar things about like MI and stroke, there are risks associated with it by itself, although they don't kind of make a huge difference, but a combination of age, smoking status, like pre-existing hypertension, or any additional risk factor, you have to be careful, or you have to counsel the patient really well before starting on combined hormonal contraceptives. But I think in a good candidate with low risk, the benefits are so much greater. But you always have to counsel them about the potential risks.
All right. Well, thank you so much, Dr. Sridhar, for coming onto our podcast and talking to us about combined hormonal contraceptives. This was really great and really gave us a good overview of a topic that I think, of course, we should know more about, but I think we often we don't talk about very much in residency. So thank you.
Thank you so much, both of you, for having me on your show, because I've listened to so many of this. It's so happy to be a part of it. And thank you to all the listeners as well.
So once again, this is Nick.
This is Faye.
And this has been Creogs Over Coffee.
If you enjoyed this podcast, go ahead and go on to Apple Podcasts, Spotify, or Google Podcasts and give us a 5-star rating and review.
You can find us online on Twitter at KreogsOverCoff1, on Instagram and Facebook at KreogsOverCoffee. Or if you love the show and want to give us some support, head on over to our Patreon, patreon.com/KreogsOverCoffee. Send us some love. We'll send you some swag.
We have show notes for this show and every other show on our website, www.KreogsOverCoffee.com.
And if you have a question for us, or correction for any of our prior episodes, or a question for Dr. Sridhar, email us, KreogsOverCoffee@gmail.com.